So I had MSc done, and as you can tell, I still have some gaps in my teeth. I just recently done Invisalign with Dr. Newaz, and I had a concern. If anyone knows Jawley or been in the Discord or anything, I worry about this phenomenon of when you expand the maxilla, the upper incisors will retract backwards. And I was so freaking out about this that when I expanded with braces, that it feels like my upper front teeth came back, and I was trying to avoid that by any means, necessary. So during the design process of the Invisalign to get back into my bite, I made it very clear with Dr. Nawaz. I asked him, I was like, hey, is it possible if I could, help like design some of my bite? And since Dr. Jaffari and Dr. Nawaz are so creative outside of the box thinkers and trying to push orthodontics, he was like, yeah, for sure. So I thought that was really cool. So what I wanted to avoid was lifting them up. My thought process was with bite force, if I kind of just tipped them out and kind of came down, when I would bite, forward, if they were to clash in any way, the upper front teeth and the lower front teeth were to clash in any way, that the force would be distributed in such a manner that it wouldn't cause the force to come back up in this way. And I made an animation basically going over this. It's about 30 seconds long. Dr. Jafari, if you want to watch this, basically describing my thought process behind why I chose to not bring the front teeth up.
Tell me the physics you were thinking.
So I'm thinking from this angle right here, right? And if I'm biting this way, right, the angle's coming up here and the force is going through here, right? Wouldn't that keep everything going this way rather than bringing the bite like this and then all the force is getting shifted up here, right? Now you're putting pressure inward and up rather than outward and forward.
And that's where the forces are going. Whether those forces in a fully grown, mature individual are going to result in actual skeletal facial remodeling is a separate, thing.
So that was, let me stop for a second. My thought process behind the angle of the bite, and since I had gone through MSc, the sutures are still relatively quote unquote weak.
Yeah.
So I was thinking like, okay, well, I don't want to look like this, like, this as time goes on, let's say 3-4 years in the future, if I'm consistently biting in a specific manner, whether those forces could actually shift or change any part of like my mid face, which seems to be like the mid face is like the biggest, not, I wouldn't say problem, but the biggest hyperfixation for a lot of people who go through MSc.
Yeah.
So I was thinking, okay, what if, the angle of the teeth and the bite forces could actually promote forward movement of, or scaffolding for the mid face and the upper jaw. So, but what I found out was, since I didn't lift the teeth up or whatever it was, however we went about it, my upper incisors actually came back, and that was what the CBCT showed. So now, since they came back, if they're coming back, that means my airway is back, whether it's 1 millimeter or 2 millimeters, which is almost insignificant. For me, that was the opposite effect of what I was trying to achieve. So for now, I guess our goal is to not only gain back that space, but maybe buccally tip them in a manner that I gain, some real estate in the lower jaw positioning to maybe just get my bite a little bit more forward to open up some of this oropharyngeal airway.
Absolutely.
Yeah, I mean, I think that, there's some merit to what you're saying. There obviously, when the MARPs are covering your teeth and you aren't able to put as much bite force, I think we kind of mentioned that before. Do you feel like the masseters were a little bit weaker than before? Right? We talked about that, right? So I feel like, there's a lot of merit to what you're saying. Now, and I think that there's something to think about when you are reflecting on the fact that your sutures were softer and weaker after the expansion. So I think there's a little bit more merit to that than usual. I think that, the way we chew when we bite, it's evident that it affects the way we breathe. We keep our mouths open, right? So if you have an anterior open bite, you're going to have that longer face. You're probably more likely to breathe through your mouth. So the tooth positioning obviously affects the jaw positioning too. And so, the thing that I have to think about is, right now, do you feel like the sutures have kind of solidified, where it's not as impactful as maybe the day after we did the expansion? Um, that's one thing. Number two, were we really trying to lift and intrude the teeth, or was the proclination making it seem like it was getting intruded, right? So, it's also like a perspective. So true proclination, true intrusion versus perceived intrusion could be different. And so if we're trying to go to that proclination, it's going to move the jaw, the mandible forward to improve the airway. I think that that's beneficial. And that's, when we talk about MSE and the benefits of it, we talk about how the roof of the mouth is the floor of the nose. We talk about how expansion of the maxilla can promote forward tongue posture. We also talk about when you're expanding the maxilla, you get anterior movement as well, right? So it's not just width, it's also anterior movement, which then when we close up the gap with the braces or Invisalign, it now allows for the bottom jaw to move forward as well, right? So kind of piggybacking off of what you're saying, I think that if we just kind of procline the teeth a little bit, you're going to get more of the airway benefit again. As for the way Invisalign works, we at least for me, and I know definitely we see that when we're doing our Invisalign, majority of the time, especially for expansion cases, the first set of aligners, we anticipate that you're going to need a refinement, right? So the teeth aren't going to track exactly the way we plan the bite in the teeth to end up, which is 1000% normal. In fact, there's because we're on the perfectionist side of things, there isn't usually a case where we're done without a refinement, because we want it to be as perfect as possible. If the patient's already enduring expansion and Invisalign and doing the time and the energy and the effort, it makes sense to make it as perfect as possible within reason. So regarding your treatment, I think that we're still net positive in terms of the gap and the aesthetics. Now we want to go back to a little bit more net positive, I'd say. Yeah, I don't know if that I don't know if that's logical sense, but we want to go from you're still net positive from before the MSC, right? Now we want to go back to a little bit even better than where you're at right now.
100%.
So do you see my screen?
Yes. Yes, I do.
So basically, when we submit a refinement, this is a refinement screen, so you can see the additional aligners. So I'm just going to quickly go over this. Basically, these are different reasons why Invisalign, as a lab, wants to know why we're doing what we're doing and what we're doing. So I'm just going to say treatment plan change. That gives us a lot more options, when we're actually designing the case and the first edit that comes back. So I just want to go over kind of some of these things. So if you click on some of these, they usually, most of these cases, Invisalign will do retractive orthodontics, because that's what most orthodontists and dental dentists do. So if you look right here, if you say correction of class 1, canine and molar, they'll also give you sequential distalization. It's the opposite of what we're looking for. But that's so common that that's what you get.
And so what do you guys do?
This is just for the prescription. Usually when we're doing MSC post or FME post patients, this is irrelevant because we're trying to move everything forward. Because why would you want to open up space and then push it back? It doesn't make any sense. So the diastema that we have, we move the teeth to close it. Right? So we move the back teeth forward to close the gap. Now, the reason why a little bit different perspective is when we have patients that naturally have diastemas, very common amongst African American folks, the majority of orthodontists and dentists that do Invisalign will actually close the diastema by pushing the teeth back. So the way I look at it is, why was the diastema in the first place? Does the patient have a class 3 bite that, having the teeth forward and above the bottom teeth allows the patient to chew and eat? Okay. Is there a tongue thrust that's pushing the teeth apart? So by closing the gap, are you going to make airway and breathing problems worse? You make snoring worse by constricting the tongue. Like, are you caging in the tongue? Does the patient have what we call a Bolton discrepancy? Are there in ratio between top and bottom teeth? Are the top teeth in a ratio that Dr. Bolton came up with smaller than the bottom teeth? And if so, then the body wants to keep those spaces, right? So a lot of times, majority of the time, I actually won't close diastemas by pushing the teeth back, because that's not what the body wants. So what I sometimes do, if the patient doesn't really need an expansion case, I will redistribute the spaces while trying to not close up or constrict the arch. So what I'll do is, instead of the gap being in the middle, right, like let's just say you have a gap between the two front teeth, what I'll do is I'll move the gap to, let's say, the canine and the premolars. So they still have a wide arch, but they don't have that gap. Now, if you look at them from the side, like a side profile, you can see that there may be a gap, but most people don't look at that person from a side profile. Most people are concerned about the frontal anterior view.
So is it easier to retract? Is that why most orthodontists do it?
Significantly easier, because by moving the back teeth forward, the back teeth are multi-rooted, right? So anterior teeth are single-rooted, right? So it's easier, they're conical shape, so it's easier to kind of move them. Back teeth are significantly harder to move because they're almost like 3 anterior teeth combined, right? So this is the crown of the tooth, and now the first molar, for example, has 3 roots kind of like this. So to move that whole thing through the bone is significantly harder than one tooth with one root. Plus, that's just not how we were kind of traditionally taught, right? So, going back to how I had my orthodontics and Dr. Newaz, we had extractions for premolars, and then what do? They push them back, right? It is, that's kind of how we were taught logically, just close like this, close like this. It was never closed by opening, right? So it's a little bit contrary to what we're traditionally taught.
Interesting.
Yeah, so just for prescription purposes, we're just going to do this. This is not necessarily how we're going to move forward with the prescription once it comes in. I say place attachments as needed. Usually we click on virtually remove all existing attachments. Sometimes when I strategically put on attachments, I put on a lot of lingual attachments on the canines, especially the bottom ones. Kind of helps me intrude or extrude teeth. So if it's a strategic reason why I put a non-optimized attachment, like a traditional rectangular attachment, I will usually try to keep it just so I don't have to do double the work, because that's my personal preference on how I put attachments on. Unless obviously it's falling off. So for this one, we're going to put virtually remove all existing attachments and put new ones on. Now, I put perform IPR as needed. They don't usually do IPR, but we just do that just because that's kind of like a prefab preference.
What is IPR?
But for you, we're going to put do not perform any IPR, because we don't want to. So IPR is interproximal reduction. It's basically when we, for a non-politically correct way, it's when you're kind of reducing the enamel, you're sanding down the enamel between the teeth. Generally speaking, It is not detrimental to the tooth because it's a minimal amount. If you were to, the amount of IPR we do is usually about 0.1 to 0.5 millimeters, which if you look at a piece of paper, it's probably about 0.1 millimeters in width. So it's an insignificant amount, but when you're doing it on adjacent teeth and you're doing it over, like, let's say, anterior teeth, if you think about how a cylinder or a cone is, the a little bit of reduction on the top is a big reduction in the cumulative effect. And so just a little bit of IPR can help with, one, aesthetics, but bringing in the teeth a little bit. Now, obviously, for a patient that has airway issues, we don't really want to do IPR. It's kind of like at a last resort. And so generally speaking, we don't normally do IPR in our expansion cases because, once again, you're constricting the arch. As small as it is, each person's effect varies. Now, one reason why I do IPR as a general dentist is because when a patient has crowding and now that crowded teeth are now straight, oftentimes you get what we call a black triangle. And it's very obvious when you look at space between the teeth. So some people have a black triangle appearance. So that black triangle appearance, cosmetically, it bothers patients, and the easiest, I guess, most predictable, stable, long term for me is just do a little bit of IPR right on the incised ledges, right? So instead of the tooth looking like a full trapezoid, you make it more rectangular shaped. And so that improves aesthetics dramatically, while not really affecting the enamel that much. Albeit you're still technically shaving that enamel. It's a question that patients ask. We say, it's minimal amount, but technically it is. Okay, and usually I think there's been studies, I can't recite them, but from what we were taught, that the incidence of caries is not increased because of that. All right, so over here, once again, I'm gonna put none, just for the preliminary prescription. All right, now over here we can say, once again, do not retract anterior teeth, move posterior teeth forward to close spaces, procline anterior teeth slightly, widen arch dentally to match maxilla. Now, it's a pretty simple prescription. Once again, this is not the final. This is just what we're going to get back from Invisalign the lab. Any questions on that?
It's funny that you have to add "do not retract the teeth." I know it's like a standard part of the procedure, but you'd think by now they'd see y'all's names pop up and know exactly what you're gonna say for these MSC.
Actually, so Invisalign, obviously there's a lot of moving parts. So it depends. Sometimes we get, like, we'll have, you kind of get a random lab tech to work on your case. However, depending on the number of cases that you do, you start getting, I think, more like dedicated staff to that. But either way, the staff, the lab techs don't actually go through the clinchecks like you want them to. So I try not to get upset when I get a bad clincheck, but I will actually verbalize it like terrible clincheck. Like,
Yeah.
why? I mean, you can see that the patient is very constricted in the first records. You can see they have all of these spaces in the second set of records. Why would you close it if you knew logically that we did expansion? I try not to get upset because there's some tech in Costa Rica that It's probably doing 10,000 of these in a month. So, but anyways, yes. So you want to make sure you put that instruction in. All right, so now we look for your scan.
I have a
Yeah.
question. So the lower arch, right? You're saying on the lower arch, the molars are far back in the lower arch. Does that make sense? Or I guess they'd be back here. And these are the front teeth up here. You're saying the molars are back. You want to bring kind of all the teeth forward, is what you're saying.
So when we traditionally look at the bite, we want to get something called class 1 molar and class 1 canine occlusion. So basically right here, the mesiobuccal cusp, the front cusp of the first molar, the maxillary tooth, should be right in the central groove of the mandibular first molar, right?
Okay.
And then the canine should be between, the maxillary canine should be between, the tip should be, the cusp should be between the mandibular canine and the premolar. Okay, so you can kind of see how the top teeth in this post expansion are a little bit more forward than the bottom teeth. So the canine, the bottom teeth should be more forward, or the canine should be back. Obviously, we're not going to bring the teeth back, the anterior teeth back, because that's the opposite of what we want. Okay, so let's go through the video. So the plan that we came up with is actually very good because we're moving the teeth forward to close up the diastema. So before, moving the teeth together to close up the diastema while also keeping the arch wide and not undoing your expansion.
Mhm.
Do you see that?
Right.
I would love to tip those upper front teeth out a little more. I know from there it looks like they're already kind of really out.
Not so. Kind of what I was alluding to before. You can plan a pretty picnic. We can't predict the weather. Like, you know, you can have this great plan, but the way the human body responds to the plastic, is the patient compliant? Is the patient, you know, wearing them like we want them to? Are they using the adjuncts that we want them to do, like the munchies, you know, things like that. So the plan is the plan. The way the body and the execution to the plan responds is different. So so sometimes what Dr. Newaz and I will do is, we understand that some of these plans don't work out the way we would like for them to, so we sometimes do what we call like overcorrection, or we build in extremes or more than what's going to translate. So like, let's say we want the tooth to actually be like that, we'll actually like program in the aligner to do that, so that actually comes out that way rather than stay, right? So that takes a lot of experience. Most clinicians don't really know how to use Invisalign like that, and don't have enough experience to properly plan for that. But we do that because we've done hundreds or thousands of cases combined. So we kind of know how to plan for these things. We know how to use the controls. But anyways, to go back to what I was saying, is now if you go to the end of the treatment, you can see how you still have an overjet. So the top teeth and the bottom teeth aren't touching.
Which is fine by me. Because I feel like my lower jaw wants to come forward all the time.
So,
Okay.
so basically, you have a 3.4 millimeter overjet. Okay, approximately. Okay. So theoretically, we can tip the bottom teeth forward, or we can actually move the bottom jaw slightly more forward in an anterior position to close up that overjet. So
Okay.
I prefer, for my expansion patients, to move the bottom jaw forward rather than tipping. Now,
Right.
you have to be very careful with tipping because the anterior bone is kind of thin around these areas. Right? So, you know, usually when we tip, we kind of move the whole body of the tooth, so the root is tortlingually, which is a little bit, not in my opinion, looking at, you know, hundreds of CBCTs, There's a little bit more bone, I feel like, on the lingual component of the bottom teeth, definitely more bone on the lingual of the top teeth. So tipping the whole root is okay, but still not ideal in my eyes when we have the jaw to move forward, or we can try to move the jaw forward. Now, that repositioning the jaw does take a lot longer. There's obviously possible risks to that too, but some of the unintended consequences of a mandibular advancement device for sleep apnea. So when a patient has a class 2 bite, by wearing a mandibular advancement device for years, they actually become a more class 1 bite.
Really?
Yeah, and we can probably go over an article at some point. That's an unintended consequence of mandibular advancement device therapy. So for a patient that already has a class 3, do you really want to advance their bottom jaw more? Probably not. Or a patient that's class 2, using a mandibular advancement device can actually yeah. And so now if you do that on purpose, that's like I do that on purpose for my patients.
So I have a question. What if someone is from their bite a class 2, but due to some temporomandibular joint positioning problems, they're actually a hidden class 3? What are your thoughts about that?
Yeah, so this is a very good question. When we are looking at this model, we're looking at this patient, Bailey, in this circumstances, teeth only. We're not looking at his face, we're not looking at his nose, we're not looking at his airway, we're not looking at, the cephalometric numbers, we're not looking at, skeletal points in this view, right?
Right.
So, once again, if you're, as a clinician, only looking at this one component, like, you can be missing a lot, right? And so that's why photos are extremely important. Your interactions with the patient are extremely important. Reading the CBCT is extremely important, right?
All of them in conjunction rather than a standalone look at the teeth.
Correct. Because if you were just look at the teeth, then if anybody saw this clincheck and they didn't know what we were talking about, they'd be like, this does not make any sense. Why would you keep space in between the premolars and molars? Like, these orthodontists are kind of nutty, right?
Yeah.
But no, like, this is the type of stuff that we do, right? So I say, I gave you the option of, do we want to use rubber bands on the teeth? Now, there's pros and cons. One, super easy. I can literally build in what we call precision hooks into the aligners. So put a hook right here into the aligner, hook right into the aligner, and try to move the bottom jaw forward. Now,
I do have a question. That was what I was in when I had my Invisalign, was that back molar, the lower molar, and on the canines. I had rubber bands, and that's what it was doing. I personally think that it put more pressure on the maxilla than the mandible because of how often I was wearing it. Now, I don't know.
well,
I don't know.
yes. The objective of your orthodontist was probably to retract the top teeth, right?
Right.
So none of this plan dentally is going to be retractive. So one of the reasons why I'll build in the precision cut into the aligner versus an attachment onto the tooth for the elastic button, because I want the whole arch to the aligner to function as like a unibody piece.
Okay.
To not pull a tooth back, but like let me anchor the whole maxilla to the mandible. Same thing.
And then,
So that's where my question of where does that force get distributed to, right?
Yes.
If it is pulling on the lower jaw, right? From that anchor, where is that force going? From
Yes.
that canine. Can that affect the midface, right?
Possibly.
Especially in a patient fresh out of MSE. And is
Yes.
this something you have to be careful with? Like, you can't apply, from my perspective, traditional orthodontics, the same forces to a patient fresh out of MSC because the sutures are weak. So
Correct.
can't that affect? So my question is like, when I relax my jaw, all right, I'm here. All right, there's like a gap. My lower teeth are in front of my upper front. Does that make sense?
Mhm.
By probably 2 millimeters, 2 to 3, maybe 4 millimeters. That might be significant in tipping terms, but for me, that's just what feels comfortable. Um, so the question is, or the options from what I see is we can either keep the lower front teeth back, right, and then tip the front teeth out so the jaw can come forward, but sacrifice some of this dimension in the chin, or we can tip the lower teeth forward to try to gain some of this back from the clashing of my lower jaw wanting to come forward, clashing with the upper teeth, causing some sort of recession here. I believe that has happened to me. And in order to gain some of that back, you'd have to tip it out. And then, of course, as you bite down over time, it could maybe build some of the alveolar bone back.
Possibly.
And if I were to keep that forward, and then we were to do some sort of maxillary protraction, that would not only give me some of that volume back in the chin, but allow for the jaw over time to get back into that new position, the position it wants to be.
So
Yeah.
bite down on your back teeth right now. Okay, so you have kind of like a deep bite still. Bite
Yes.
down. Yeah. So your jaw is literally being caged in by the top teeth still.
Correct.
Yeah. Okay. All right. There you go.
Now now I see you. I did see it.
Okay. Good.
Yep. See your mouse now.
All right. So yeah, so we could tip them out a little bit. We can so the key is, if you look over here, the key is bringing those bottom teeth down, right? To decrease the deep bite that you have. Because right now the bottom jaw is kind of locked by the top teeth,
Okay.
right? So you're in this retruded mandibular position because the teeth are physically, and so the goal is to slightly procline and minimally intrude even the top ones, so that now you have more flexibility of moving that jaw forward,
Okay.
right? Because right now you're kind of stuck,
Right.
right? Now that's that's kind of what we want to do. So how do we get there? Well, going back to the pros and cons of elastics, the pro is it's simple, it's easy. Con is exactly what you're saying. You know, every force has an equal and opposite force on it. So if your intention is to bring the mandible forward, are you unintentionally bringing the maxilla, putting pressure on it to bring it back? That's more pertinent if you just came out of MSC, but something to be very mindful of, right? So one way to maybe counteract that is using a TAD. So could we put a TAD, a temporary anchorage device, a mini implant over here that's on the bone, and then kind of bring the teeth forward? That's possible. You know, you're not putting any pressure on the teeth. Now, theoretically, could it still be putting pressure on the maxilla? Yes. But I'm less concerned about that versus putting pressure towards the arches. That's one option. Now, another option that we use is like a mandibular advancement wings on the actual Invisalign. And so what we do is on the aligner, we put these plastic wings that kind of forces the bottom jaw forward.
Okay.
So that's for a class 2 patient, usually. So a patient that has that look. I have successfully using it off label for treating some of my patients that are currently in Invisalign that also have like snoring and sleep apnea. And so far we've gotten some really good results too. Yeah.
Okay. So, what are your thoughts about me getting back into headgear? Because I will be compliant. Like, I will wear it at least 12 hours a day. At least.
Let's what I'd say is let's talk to Dr. Newaz and look at the CBCT, and because if you want to do like baller plates or something like that,
Whatever.
what I would say is, you know, we designed with one of our patients a really cool and innovative baller plate combo where, you know, we worked with the lab to put in, like, secure the plate to the teeth, and then also looked at the CBCT and then put tags that we designed into the maxilla from like a dental perspective versus an oral surgery perspective. Very innovative, very cool. What I would kind of say is let's do this stuff orthodontically, like now, right? Like you can see how in this case, like the incisal edges of these two front teeth are much lower than the laterals. Let's intrude this a little bit. Let's try to do as much as we can orthodontically first. Then we can have nice positioning to even do this bollard that we can customize ourselves versus going to the surgery room.
Okay.
Right. And then now if you, like, let's say close up all the spaces, then you can, if you want to pull orthodontically, your arch is set, then pull as, you know, within reason and see what kind of results you get.
And so,
does that make sense?
Yeah, that
I'd say like finish, quote unquote, the straightening of the arch, the intrusions, like the stuff we see orthodontically. Then if you want to later on, like, you know, we can customize that, you know, type of bollard plate that we've done before, put it on, and then you kind of go to town for, you know, within reason, how much maxillary protraction you want to get. That's one option.
I think that is a really solid option as well, because if my restriction is simply the maxilla being too far back and my bite wants to be here.
Well, it's two things. You know, it could be the maxilla still not being forward, but it also could be the fact that, which right now, looking at your clincheck and your bite, the teeth are trapped right now. Right? And that's why Dr. Newaz wanted to intrude these bottom teeth and then procline these top teeth and do a slight intrusion. And I think that you didn't want to do as much intrusion on the top, right?
Right.
But
because
because of the angles that you showed me. Yeah. So I would say, you know, let's focus on the dental for now. Get the arches kind of steady, especially the top. Then do the customized semi-bollers that we kind of created, and then kind of pull, and then finish up with Invisalign after we've gotten a good amount of pull. And now pulling works, protraction works. I've gone from a complete class 3 patient like this to, you know, an MSC diastema bite within 9 months on a female patient who's like in her early 20s. We've gotten 2 millimeters of protraction on one of our patients in his late 30s.
Wow.
And so since you're still very young, I mean relatively young, I think that you'd get pretty good results.
And I am somebody who wants to avoid jaw surgery. Like,
then this is the route.
I don't want it. I want to avoid it. And that's kind of been my thought process for this entire treatment was, okay, well, I don't want to get jaw surgery. What are my options? What are the alternatives from having to go through jaw surgery? So, you know, if I have to be in headgear, then that's what I'll do. But like you said, getting into that bite, I think would be extremely beneficial.
So see this like initial setup?
Yes.
So this was what Invisalign's first clincheck was, and obviously completely opposite of what we're looking at, right?
Mm-hmm.
So you gotta see how what Invisalign does is retract
That's crazy.
Now this isn't that bad because they understood, the techs probably understood, and the way Dr. Newaz probably put a prescription in is like, don't close up this, don't retract. They retracted intelligently and then distributed the spaces, right?
So I have a question. What if I wanted to bring my canines down? Would that be a problem? Like aesthetically, what if I wanted that vampire look? You see at the top of the canine where it meets the gum, you see how it's like higher than the rest? It kind of looks higher than like that back molar.
So the canines are higher generally aesthetically than the premolars and the molars. Usually when we plan it out, we want the anterior, the centrals to kind of be similar to where the canine is. So you can see how your right canine and the centrals are pretty similar. Your left canine is about a millimeter, the apex is about a millimeter taller than the other 3 teeth.
Okay. But would it like functionally affect anything if I, as a patient, was like, oh, I want my canines down, or oh, I want my front teeth, like that arch gum line down a little bit? Like, would that affect anything functionally? Like, what if I was just going for aesthetics?
So when we look at function, we want what we call canine guidance. So the canine is the longest clinical crown. So even if you look at all of these teeth, it's literally the longest. So if we, let's say we measure, it's 11.6, let's say. This is 11.6, right?
Mm.
You know what? I don't like that. I don't know. Let's try it again. Okay, so let's just say 10.5, right? And then we, okay, so the canine is longer than any other tooth, right? So it's also the longest and strongest root inside. So if you look at it in nature, when you see like a lion eating a hyena, they always go in from the side.
Yeah.
Right? So the canine is the longest clinical crown. So when you move your jaw, you want your canine to be the only tooth touching, ideally. There's 2 canines. See that?
Yeah. I see.
Okay, so that's called canine guidance. Okay, now that's a protective function because the canine has. So when you look at they've done like pressure analysis of teeth, and the way each tooth. If you hold on, I can actually bring a textbook and show you this.
Okay, go ahead.
So we have this trusty book series, Biomimetic Restorative Dentistry. So when you look at how teeth have forces applied to them, pressures that a tooth gets, the way the pressure of the tooth is, right, can affect the wear patterns of the tooth and the susceptibility getting cracked. Okay, so anterior teeth are not meant to get a lot of forces based off of their positioning. right? So the incisors, and the analogy I give incisors is similar to the word scissors. So the scissor blade should be close enough to cut paper. So if you take a scissor, close enough to cut paper, but they actually can't be hitting each other. Because if they do, you won't be able to cut paper. So the incisors you should have enough overbite and overjet that they don't actually hit each other. Because when they hit each other in an improper manner, you get significant force issues. Okay, so you get a lot of forces, right? So you can see like where the red is, you don't want forces in those areas, right? It creates a lot of forces. So canine,
demonstrate, like point, like what we're at, you know, like use your finger to.
yeah. So basically, your incisors are cupped, right? So let's just say like your top tooth is cupped, right? So your bottom tooth is coming in, right? So if you're hitting hard, you're actually hurting both the top and the bottom teeth, right? So you want it to be more like a gentle slide. So you're not hitting, you're like.
And this applies to which teeth? Just the canines? Or
No, this applies to the anterior, the incisors. So you don't want the incisors to hit because they're meant to cut, right? So if you're biting in a sandwich, you can put a bologna sandwich or a turkey sandwich, you bite into it, and then the turkey and the lettuce stays inside your mouth. It comes out.
The molars are for force, and then the incisors are for scissor. Like
yeah. And so the canines, on the contrary, because there is no like, so the red part that you're seeing, it's like a cupped area. So the incisors have a cupped area. So if you look at the clincheck, so let's just say we go over here. To see how they look cupped?
Yeah.
Right? Now the canine on the opposite, see how both sides look like mountain peaks?
Yes.
Right? So the forces are better handled by a canine. Right? So you're not destroying the canine when you're putting forces on it. Okay? Because there's no cup. So when you have a cup, the tooth is cupped, it's getting a lot of forces and it hurts it. Right? So you're putting tooth. So that's why incisors, you want a very gentle, barely touching.
Right.
You don't want this. So a lot of times when people have crowded teeth, that when they age, they really destroy the incisal edges. They get grazed lines in their teeth and things like that. Now, going back to answering your question, if you look over here, you can see the canine. The canine is like a mountain. You see that?
Mm-hmm.
So it's like literally you can ski down this. To see how like you have this really nice enamel over here, you have this really nice enamel over here. It looks literally like a mountain, like a typical mountain peak. Okay, so the forces are distributed really well, and there's nice enamel on there, and it's the strongest, longest tooth in the mouth, the canine. Okay, so it does very well with forces. So you want something called canine guidance, right? So only tooth touching. So if you were to grind your teeth, that's only tooth touching. See that? So you want the canines, when you move your jaw and you're biting a hyena, to be the only teeth touching because you're ripping meat. Right? Now, I mean, the human body is a miracle. So now if you look at the molars, let's just say right here. So the molars, you want them to basically interdigitate, right? Because they're masticating. So they're like a gear chewing corn and wheat like a cow, like a horse.
Yeah.
Right? And so when you're chewing, you actually chew in a figure 8 motion. Right? You don't chew up and down. Most people think that they chew up and down. They don't. So your tongue is keeping the bolus of food back and forth on the teeth surfaces, on the molar surfaces.
Right.
So you need that motion.
Right.
So the tongue plays a big part in that, right?
Right.
And so, you want to have, see how these molars are kind of like interdigitated nicely, right? Like the tip of the bottom teeth is in the groove of the top teeth.
Yes.
See that from this angle?
Yeah.
So now when you move your jaw, you're kind of crushing food. Yeah. So going back to your question, yeah, within reason, you can bring the canines down, but you also don't want to destroy the canines because that's the only thing it's touching.
Okay.
Right. And then also, I mean, let's see. So over here, this is a different measurement. Okay. So this is what the Bolton analysis, that Bolton number I was telling you about before with closing diastemas. This is a ratio. This is not an absolute number, but this is a ratio. And you can see that if you were to, in an absolute term, your top teeth are wider than your bottom teeth. Okay. But the ratio, you want it to be basically, you want this number to be a 0. Okay. So right now, your top teeth are, so mandibular excess. So your bottom teeth in ratio to the top are larger than the top are. So your top teeth could be larger for your face.
Okay.
So sometimes when I see this, I'll ask the patient, hey, do you want me to actually, not, this doesn't apply to you, but do you want me to actually close up all the spaces, or do you want me to keep strategic spaces so that number becomes a 0 and we could eventually do veneers or bondings, right? And I actually think that because if you look at your laterals, see how they're kind of like very like pointy, like they're very flat. They look kind of rectangular.
Yeah.
Right, and you can kind of see that. So for you, I would even at some point be like, hey, look, Bailey, I think that we could make your smile even more aesthetic if we did, like, let's say 4 veneers.
Right.
Right, rather than closing the spaces, I strategically keep the spaces and then do these very minimally invasive, almost no prep veneers.
Just on the incisors.
Yeah, I think the incisors should be fine.
Interesting.
Yeah. And then now, like if we're talking about aesthetics now, you could see how your teeth are very like straight. They're very the body of the tooth is very rectangular. Right? So teeth are not as rectangular usually, right? They're more like ovoid-ish looking. And so that's where you get that space again.
Got it.
Does that make sense?
Yes.
So if we weren't going to do protraction and things like that, then I would actually plan to keep spaces for aesthetics.
Yeah.
Now I bring that up to patients because once we close, then you're closed. So, because obviously there's a financial ramification to that for patients, right? So
Right.
then I have to plan that out to get the nicest, minimally invasive, minimally prepped veneer. And so the more space I plan correctly, the less drilling I have to do on the tooth, right? And you want to maintain as much enamel because when the veneer is bonded to enamel, it's very strong. And that's actually another part of the book is sometimes teeth that are weakened from wear and tear and improper positioning, you can actually strengthen by putting a minimally invasive porcelain covering. Now you're making the tooth stronger again. So most people look at veneers as a cosmetic thing, but veneers can actually be a beneficial thing to increase the longevity of the tooth if done properly.
What about building height, like of the molars? Say I wanted to have like a taller bite, would that be something?
Yeah, well, so basically what we do at that point, we'd measure, from your forehead to what we call the glabella, and then from, right at the forehead to the nose, to the bottom of the chin, the bottom of the nose. And if you have that, like, proper thirds, like my forehead is very large compared to, because that's like a receding hairline, but like this is pretty normal. And then now you can see my forehead is extraordinarily large from being a balding older man. But so we would say, okay, you know, how is the aesthetics, you know, how is the functionality, right? So sometimes by opening up the bite, you can improve the airway as well, right? So some of our patients, we want to strategically, and that's the benefit of coming to Newaz and I, because we do cosmetics and we do you know, functional dentistry. So I can actually build up the bite and help, you know, some types of snoring sleep apnea symptoms too. The problem is that it's very expensive
Yeah.
for the patient
Right.
because it's a lot of work on my end.
Right.
But we've seen some amazing stuff. You're kind of building in a sleep appliance permanently for the patient and improving their jaw positioning too.
So
Right now, based off of what you're looking at, step by step, in a nutshell, bullet point, what are we gonna do? What would you suggest doing?
Step by step, we're gonna do the Invisalign. We're gonna definitely close up the spaces in the interior by moving the premolars forward. We're gonna kind of maintain the space between the premolars and molars. We're gonna intrude the bottom teeth. Already kind of what we planned out, right? We're gonna intrude the bottom teeth so that your bottom teeth are not stuck behind the top teeth. We're gonna procline the top teeth a little bit, do a little bit of intrusion, nothing too crazy, and then see what kind of result you get, and then that could be that phase of it, and then, you know, try to get the arch as stable as possible. Then we can consider maybe doing the customized ballers that we would do, and then bring the maxilla forward, and then try to inch the mandible forward too.
So inch the mandible.
Yeah, with the protraction, but then we'd have to do Invisalign again to make sure that your bite is in proper occlusion and coupled properly.
I read somewhere on a study that the TMJ can actually adapt up to 4 to 5 millimeters. So if let's say my jaw already wants to jut forward, let's say a few millimeters, if we bring the upper teeth forward and we bring the maxilla forward, would the temporomandibular advancement even be necessary?
So that's a great question. I mean, you know, we're repositioning the jaw minimally. So this is not a replacement for jaw surgery, because jaw surgery is significantly more. And so you're waiting for the jaw to remodel, kind of like what you were saying, and adapt into these forward positions, right?
Okay.
So there's obviously, like I said, risk with anything, but going back to what I alluded to before, and said that sometimes when you use a mandibular advancement device for many years, one of the unintended consequences of that is a better bite, because the jaw has repositioned forward. Now that's a good consequence, nevertheless it's still a consequence. So, and that person is still functioning well, they don't have pain, so obviously the jaw is remodeled.
Right. And if the lower jaw comes forward, you would then need more room for the upper and lower teeth. Right? Like if you're wearing if the maxilla is here and the jaw is trapped here, right? But it wants to be here. Right? So if you bring this forward and the jaw's already here, like that's a really good thing.
Good thing.
Correct. And then most of our MSC patients and expansion patients get that benefit.
Right.
But if you are trapped here and the jaw is right here and you wear a mandibular advancement, can't this be a problem?
Correct. And so that's why we, you know, when you're doing a mandibular advancement device, the patient must recalibrate their jaw every morning with like a wafer or chewing, things like that. So like we call a morning occlusal guide. So they bite into this thing that gets them back in that position. Because over the years and years and years, that slight movement, if they're not going back in the posterior position, they will literally get a an underbite.
So if they will literally get an underbite, yeah. So if the front teeth are like this, right, and the back teeth want to be right here. If you bring these forward, the only thing that's restricting the lower are these incisors. If you were to tip these out, right, boom. So what would a lot of I guess flare or just tipping the upper front teeth out to allow the jaw to be here. What's so bad about that?
Um, I mean, aesthetically, that could be an issue, but um, I wouldn't say it's bad. No, I mean we do the Dr. Nawaz does that. And even when I show him some of my clinchecks, he will actually do that even more than what I already planned out. So we do that all the time. It only makes sense because the jaw is basically being constricted by the teeth, right?
So
So
would
the
you call that a class four? A class four is a hidden class three?
That's funny.
Yes, sir.
Yeah, I mean, I don't know. I wouldn't say that. Yeah, I mean, so I'd say let's for next steps, let's actually design the clincheck. All right, so let's get back into this. All right. All right, so let's play and see what the so now we can see that the front teeth are moving forward. Before, after, before, after.
Is it in any way possible to slightly shift the um, front teeth on like the x-axis to the right slightly? Because I feel like the
The right.
midline of my bite, yeah, like
Yeah.
towards, yeah, I feel like towards the left side of my face. I feel like my two front teeth are more to the right of my face by maybe a few millimeters, nothing crazy. Oh, wait, you did. I think you might have.
These are two different clinchecks.
Okay, sorry.
They look pretty similar.
Which is the one on the left, the old one?
And I think one of the staff added a generic prescription.
Okay.
It looks pretty much the same. Yeah, it looks the same to me. All right, cool. So let's just X this out. All right. And so did we talk about elastics?
We did. I wasn't entirely convinced.
Okay, now how does this overjet look for you?
Fine. I want a little bit of the overjet. That's fine by me.
Now, did you want to use a mandibular advancement arms to move
Um,
it?
I mean, what does that look like? Just in a nutshell, briefly.
So the aligner has these wings on them, like right about here on the top and one on the bottom. And so basically it's forcing the bottom jaw forward. So the wing would be like over here for the top. The
Hmm.
bottom one would be over here. It'd force your bottom jaw forward. Now we don't necessarily need to do this right now anyways. We could move forward with what we've kind of worked on right now and
Right.
see because you're doing a lot of movements. A lot of times, the Invisalign, as much as you want to plan a pretty and a perfect clincheck, the way it translates into your mouth is variable in every patient.
Right.
And
Is it
so,
possible to tip the front teeth some more?
yeah,
Those are the only thing. The advancement thing, I'm not sure. I feel like my jaw kind of naturally juts forward, anyways. So I'm not.
do you like this overall position?
Yeah, yeah. I think it's okay.
Let's go over here. So what we'll do is let's procline some of these teeth. You kind of see how it's trying to tip out a little bit.
Hmm. Do you have to move the canine with the rest of the teeth?
No, let's go back. Now let's procline those and tell me what you think is good. You want more?
One more. Yeah, let's see that.
That increases your overjet though.
That's perfectly fine. I kind of want that a little bit because I'm stuck in this weird trapped bite. So I don't mind if those three teeth are a little forward or four teeth. Um, and then also like the midline of like my two front teeth.
Mm-hmm.
Did you change that at all?
Um,
Not yet.
how do you like it so far? That one, if you're gonna change it, then I'll have to put in a prescription for that because it's a lot more time intensive. So basically, I have the text do that for me.
Okay. Yeah, it's just like the midline of my teeth. It's like
Mhm.
I feel like it's off center and it's very frustrating.
You
Um,
mean to your current face?
and then go back. Switch between the two really quick.
I wouldn't take into account with the way you look right now
Okay.
because your teeth are very crooked right now.
Right.
Like, one's higher than the other, one's lower, you know.
Hmm.
I would not. I would basically go, let's start with this because will this actually track according to plan? Um, moving these premolars is going to be challenging, right?
It yeah, go but it looks like the back molars, the upper back molars are being put back. Or is it an illusion because the front teeth are going forward?
So see this, it's an illusion. So see how over here it says the translation?
Yeah.
Yeah, so it's actually illusion. It's still moving, but it's not actually moving back. Now
Right.
let's look at the bottom one. Hold on. Bottom one, no, same thing. They're not moving forward. They're not moving backwards.
Right.
Same thing. Yeah, so none I don't think any of your teeth are moving backwards. Maybe this one, but that's okay though.
I've had this concern
Hmm.
and you can alleviate it, but it's like my upper front teeth being um put up. I forget the my brain's not
You
working.
did?
Intruded, correct. And I
Hmm.
feel like it's gonna affect my smile. Like I like being able to show teeth. Um, and I feel like if it's way up, I'm gonna look like a Goomba. Or maybe the lower teeth are just being brought down and it looks like way different. But
Yeah, I think a lot of it's the lower teeth,
okay.
right? Yeah.
And
Now,
is it necessarily, are they going down? Are my lower teeth going down or are they coming forward?
Your lower teeth are definitely coming down, and they are also coming forward a little bit.
Okay.
Mm-hmm.
Um,
To see that.
why do they need to come down? I trust it, but I'm just curious.
So see how so if you look over here, the way your bite is right now, you have what we call a large curve of speed. So it's kind of like a ski slope,
Okay.
right? And so the way your teeth are positioned, the top teeth, so they're tilted down and inclined. So your jaw is kind of pushed back right now.
Okay.
It's forced back for the combination of the two. Okay, because your front teeth are down and tilted back. We need to bring them up a little bit and tilt them forward. And then the bottom teeth need to be tilted down and move forward too. Right?
Okay.
That should free up your jaw as well.
All right. Yeah. Aesthetically, it's not gonna like make me look crazy or nothing. I'm not gonna lose like chin height or
No. Because this is the front. The back is mostly where your vertical is.
okay. I've just been worried about like my
In
chin.
fact, actually, this will make your bottom jaw kind of come forward a little bit.
Okay. And then the shape, the reason why I wanted to kind of tip those four top incisors like out like that and kind of keep the canines a little out of the way so that we can kind of tip maybe we were talking about this last time, like whether it's ideal to allow the keep the lower front incisors back, that way the lower jaw can come forward, or compensate by kind of tipping the lower teeth out a little bit to add a little bit of volume to the chin, because that's really where I feel like I'm struggling right now, and I feel like I've lost maybe some bone density from resorption or relapse, and not lack of bite force. So I feel like that's the biggest change I've seen in myself is in my chin region. And I was curious if whether, tipping the lower incisors out would alleviate that, or whether we keep them kind of tipped lingually back and just let the lower jaw come forward, and if that could do anything. But, long term, what would add volume back to, or no, bone, maybe bone density? I don't know.
Okay, so great question. I think I think that the way we're positioning the teeth, your jaw will move slightly forward, right? Especially if you usually have your jaw in a more forward position, right? One, number two, we could actually procline the anterior bottom teeth too, the mandibular teeth,
Mhm.
right? To give you maybe a little bit of more that support around underneath the lip area. We could do a little bit. Um, what a lot of times what I like to do is actually I like keeping spaces in strategic areas. So like for example, I may keep like let's say half a millimeter behind the canine, right? Um, half a millimeter behind both the canines, and then now move the bottom teeth out, and then also tip them a little bit.
Okay.
But that's up to you. That's not mandatory.
Can you repeat that? Move the bottom
Yes, so
canine
here
out?
I'll show you
Okay.
to see what I'm doing here.
Hmm.
To
That
see,
wouldn't add like crowding to my lower.
so I'm moving the bottom teeth forward a little bit.
Ah, I like that. I like that. I like that. I like that.
Wrong space on 1 second. Let's just say I'm not doing this whole amount because that's a little too
Mhm.
for me, but just to show you see that now?
Yeah.
We're
Yeah,
jet different.
that looks solid. Yeah, I actually like that a lot.
But now what we have to do, I have to see how much that impacts this area.
Like the spacing between those two. Yeah, or those
See
teeth.
how to see how like if you look over here, translation buccal lingual, this is
Hmm.
a lot of movement for me. Okay, because some studies show that there's about 1 millimeter of bone on the facial surface of the roots. So even though this isn't going to translate 100% into the mouth, right? you still want to be cognizant. So I wouldn't want to even program 2 or 2.3 millimeters of facial movement of the roots, right? So now what we could do over here is, let's just say we take these four, and then now we see how these numbers are going down.
Mm-hmm.
And then now what we could do is, let's say go back one, and now we tilt.
I see. So it's utilizing that space that we have obtained by,
Kind
and then kind of dispersing them a little bit.
of.
I see. It kind of looks a little, what do you think?
I mean, this is how I normally would kind of transition. Like,
Okay,
because you don't want to use, so you don't want to use elastics, right?
correct.
You're still, getting rid of that overjet. I mean, still not perfect. Like, you still would want more, but I think that's a little too much
Right, right.
for me.
And then what is I guess the premolars? Like, what are the molars right after the canines?
These are premolars, yeah.
Okay. I feel for the mid-face region, going back to the bite force, the premolars connection between the upper and lower are extremely important.
Correct.
I think I really want to focus on like centralizing the bite around those premolars. It might be a little too late, but I just want to make sure the connection between the upper and lower premolars are um,
You mean
in
like how the bite looks?
correct. Like
Mhm.
those two for me, I feel have always been really strong, and I feel like that's what allowed my face to maybe develop a little more than others to an extent.
Mhm.
Um, and it could be because of the premolar position and how they interlocked when I was biting, and the angle of those premolars, dictating the force in which it was, transferred through the rest of my face. And I still feel like some of my sutures are a little weak. I don't think they're fully fused. Um, so I still want to kind of like utilize that. I know so that was one point I
So
wanted to
let's look at this. So basically, when we look at the bite, so this is all in Invisalign programming. So it's like, don't look at the colors per se.
okay.
But you can see how, you're hitting very little to none on the right side, the posterior right side.
Hmm.
You're hitting, so red means heavy versus green, which is light. You're hitting pretty heavy on the premolars, right?
Okay.
So what we're gonna do is we want a nice bite everywhere. So I'm gonna, you see how you're intruded over here? See how you're intruded on this one?
Hmm.
So we're going to see the intrusion there.
Right.
Right, so now I'm going to implement less intrusion.
So you're extruding them?
So see how I'm decreasing the intrusion. I'm not extruding them yet.
Why are we intruding the molars?
So that's how the Invisalign clincheck came back. So now we're kind of undoing that.
Okay. Yeah.
So see how now I'm not intruding them. See that?
Yeah. So I'm gonna mute myself.
Now your bite, see how it's getting more red per se.
Yes.
That's so I want nice, right? For example, these are actually true extrusions now.
Okay. Why is that very back molar kind of at an angle? It like that very back molar seems like it's not on the same uh playing field. But maybe not. I guess I don't know. I really don't want to lose any bite height. I think I had the original MSE with the molar arms, and it really flared the shit out of my molars, and I think I got a decent amount of potential resorption, and I don't want to lose any more bite height than I already have
Yeah,
due
so
to
we're
that.
gonna make sure that you have a nice deep bite.
Okay.
So, but all so what we're doing over here, for example, we're trying to level out the bite too, right?
Right, for sure.
You're trying to bring down the front teeth, bring up the back teeth,
That
things like
looks solid.
to see how like that's a high curve speed, large
Yeah,
curve speed. Now we're kind of making this bite kind of plane, you know,
right. I like that angle too. I like it. I like that angle.
that.
Yeah, I like that. Is there a way to kind of, I don't really know how to demonstrate it. The upper arch from this angle,
You want to see the upper?
from this angle, yeah. Okay. So you see that back molar, how it's, uh, that's the new, okay. Could we angle that molar, the second molar, kind of so that it's aiming, the root is aiming towards the midface?
Okay, explain what aiming towards the midface means to you.
The root of the tooth aiming towards the center, like the front of the face, I guess.
So like,
The root, yeah, kind of like that, yeah. Kind of utilizing some of that space.
all
Is
right, so
that
so so basically, this is how we normally do clinchecks.
Mhm.
Is, so what I do when I look at clinchecks is, am I am I doing anything crazy, right? For me, crazy means mostly root movements, right? So if I feel like the root movements are within, like I said, that 1 millimeter facial bone height on the anterior teeth, right?
Mhm.
Then I'll usually go along with the uh my my knowledge of the patient and my expertise. If I feel like, there's something that I need to pull out of, let's say, we're doing some different movements or things like that, then I will resort to using the CBCT as well, right? Um, so in this case, this is more of a quote unquote normal type of movement, especially on the back.
Right.
So before I start doing root angulations, I'll deviate from where it's currently kind of within norms. I would want to see the CBCT first,
Right.
right? So I would say right now, this is pretty normal, right?
Okay.
To quote unquote develop that mid face, what I hear is, do we move the roots more towards the buckle,
Mm.
right, to make the mid face theoretically larger or bigger? Um, I wouldn't necessarily do that unless we had the CBCT and there was a reason for it.
I think the reason I would give is not necessarily for appearance, but more for functionality and long-term bite force uh, impact, if that makes sense.
Okay,
So,
so there's other considerations too. For example, the buckle, right, bone is, like I said, usually thinner. It's also
right.
thinner on the molars as well.
Mm,
So because it's a three-rooted tooth, if you were to move the molars to the buckle, you are more likely to get recession too. And a lot of times, if you, let's say you tip them a little bit, then you'll also get like abfraction on the near the gum line as well.
right.
Um, and also it is a more challenging movement because you're moving a three-rooted tooth. Um, I don't know, does that answer your question?
Yeah, it does. It does. I mean,
What I would say is, once again,
good
this is a
start.
really solid clinch check. Um, you're we can do this again because
Okay.
we're gonna need to do another refinement or two anyways,
Right.
right? Because I would call this a gross movement, right? Like a gross movement, right? I wouldn't even call this a fine tuning yet.
Okay.
Does that make sense?
Yes, it does.
So, do you like these 1 millimeter spaces distal
I,
to the canines?
I do. I am happy with those. I think that is a really good compromise of like where we were and where we are. And yeah, I'm happy with that. As long as, the premolars are touching right, and of course like
So
refinement of
let's get the bite down perfectly now. Or
is that what we're gonna do now?
yeah.
Okay. And this is the lower, correct? Yeah.
Mhm. So the reason why I like to go for this red is usually what we call like heavier. I
Mhm.
like to get to the red because once again, I understand because I've done so many Invisaligns. I like the way the bite translates versus getting them to a light green. Okay. And so I feel like now the patient has a lot more tactile sensation while chewing, eating, and the bite is you're kind of overcorrecting it for the aligners.
Right.
So as you can see over here, right? We zoom in, your canine, your premolars are touching pretty nicely. Okay, canine guidance. Once again, premolars are hitting pretty nicely. I like the way they're including and coupled. Yeah. And once again, like I said, this is it's one extra step in the whole process.
Right.
So then what I do is over here, see how these 0.2 millimeters of IPR, this is all fake IPR. We don't actually do any of this.
Okay.
What this does is we kind of make sure that there's no gaps between the teeth where you're getting food stuck where you don't want it to.
Right.
So
Okay.
it keeps the teeth nice and tight. We don't actually, I don't actually do the IPR.
Got it.
So it looks really nice. While still, you're not, decreasing the width of the tooth. Once again, this won't translate the way we're planning it in the mouth, and that's understandable and that's okay. So for example, we over intrude these teeth because they're not going to actually translate. Same thing with these. So
Right.
your over bite will actually probably look better than this. And that's why you go to an experienced Invisalign provider because they know how to actually, program the clincheck to get you the result that you want.
Right.
Right? So like, if you go exactly the way the Invisalign clincheck comes out, then you're not going to get what you want because it won't, what you plan won't actually translate into the mouth as planned.
Okay. And would I be crazy to ask to bring the upper front incisors down slightly?
Down, as in like extrude them.
Correct.
Um, no, but going back to what I just said though, it's not gonna look this way.
Right.
So that's why we overdo it because it's not gonna actually look like what the screen is showing you right now.
Okay.
Does that make sense?
Kind of.
So basically,
Kind of.
because I know that your body and what my game plan right now won't actually work 100% to the plan in your body. We overdo some of these movements, planning, understanding that's not gonna be. So see how like you have a space right here,
Yeah.
like visible, and like
Right.
you won't have those after this set of aligners,
Right. Right. Right.
right? So that's why we overcorrect it basically.
I see.
Does that make sense?
And then we do the refinement. Yeah, I look at pictures
No,
from.
so don't look at it. So this is not a complete translation of how it's going to look in your mouth.
I see. I
And,
see
and so
that.
that's why people like Nawaz and I have done so many hundreds and hundreds of cases. We know how to program your clinchecks to actually get a better result.
Absolutely. And
That
it's
makes sense.
scary.
So when I first started, right? Like let's say, when I first started doing Invisalign about 10 years ago, right? I would make sure that the overbite and overjet was perfect, right? On the clincheck.
Right.
Patients done like 30, 40 aligners, whatever it is, 20 aligners. And you're like, we still need to do more because the body didn't actually translate the way we wanted it to.
Right. Yeah, it's scary for me because I am a patient of, cookie cutter orthodontics. And so I have like this, sometimes I get this overwhelming wave of, and I'm not meaning this like to you personally, but just distrust for the system of orthodontics, right? And I feel like my own interpretation, and it's just all, my brain, I'm like, oh, it's just intuitive. Like,
All
oh,
right,
well,
so
that
let's. I
doesn't make
mean, we could
sense, you
decrease.
know?
But all right, you want to decrease the
Well,
intrusion?
no, I want to listen to you. I trust you in Newaz, you know, I do. And I want to just
We
be
can
able
still
to
stage this
question it.
too. So if, like, for example, I mean, look, if we're gonna do another refinement anyways, we can see how this one turns out. And if we need to do more intrusion, we can.
Right. And my whole point is like I look back to pictures when I had a very, very developed, you know, face or whatever, and my two front teeth were like down past the other incisors next to it before the canines. And it
Okay,
looked
so let's do this. So let's extrude a little bit, decrease intrusion a little bit.
okay.
Okay. And then let's make the front two a little bit less on top of that, like something like that. How's that look?
Okay. And then I would even be happy if you brought the other two next to the front teeth up a little bit. Up to the to those two, yeah. If you brought those two up to kind of match the top of the canines,
Um,
like the
I
arch,
think
the
that
gum
works.
line, just slightly. Is there a function? Is there a function that's bad to do that?
Um, yeah, because you want the gum heights to be so the gum height of the canine and the central should be more the canine central should be more on line, and the lateral should be lower than the centrals and the canines.
Why?
Aesthetically, that's kind of the way human smiles look.
Okay. That yes, you're right. So could you bring? I guess my teeth are a little crazy looking. And then this is the problem me and Newaz ran into. I know I don't want to harp on this and you know run in circles, but those two front teeth just like slightly down and almost like a freaking almost buck tooth wise. I know it sounds crazy. It sounds crazy, but I think it adds to the smile. I
Yeah,
think it
I
does.
mean,
And
it
it,
looks also more youthful
right.
here. So
I like that. And then I'm sorry.
yeah.
Okay. Can you do the before and after? So do you see how like the canines are coming in? Are they coming in or is that an illusion?
Illusion.
So they're
I mean,
not, oh, they're coming
they're
forward.
coming forward. So
Could you,
we're not shrinking the arch at all,
right.
like
Could
in terms
you,
of bringing them back or anything.
okay,
And that was the whole goal of everything, is make the arch actually a little bit bigger, right?
right.
All right, let's check the arch width. All right, so see this over here.
Hmm.
So your arch width in the back is getting a little bit bigger. The teeth are coming in slightly around the premolars.
Is that getting smaller?
Slightly. To see how like the MSC kind of keeps the arch, how we kind of bring the teeth together.
Yeah.
But your arch is still nice and wide in the back. In
Hmm.
fact, you're gaining, and then now you're actually increasing, I'd say, arch like length per se.
Right.
Which that's not a measurement over here.
Okay. I just worry like since the canines look like they're coming in, that it's gonna clash with like my lower
I
teeth,
mean,
you know?
I can tip them out a little bit.
Yeah.
You want me to tip them out a little bit?
If that's all right.
Yeah, Actually,
Would that
I think that would look nicer anyways, actually.
along the
See
lower
that?
gum? Yeah, I see.
I
Yeah,
like it anyways, actually.
and then nice. I think that looks good. Yeah, I really worry about like the low, like the incisors, like of my smile. Like I feel like it's really flattened out since MSC.
Oh,
You know,
I like this much better now.
me too, me too. Is it possible to add some of that volume back to like the arch, like in the front, like sagittally, I guess, like over time? Okay, let's see that. Yeah, I like that. Uh, Solid. And if we were to bring the front teeth down just one more time, would that affect the front to back dimension?
Mm-mm.
Yeah, I'm starting to like that.
I think it's pretty nice now, actually. I
Can we?
really the canines now better, much better. They're less tipped looking,
Yeah.
more upright in. Yeah, it looks much better. Mm-hmm.
And
Yeah.
then all those red things are buttons.
Mm-hmm. Yeah. If you're gonna move things like mesially and distally, you need to have attachments.
Right, for sure.
And I like attachments, place them one time, and then I like to sometimes reuse them. So, they place them one time, it's gonna be a longer appointment, but then, I'll sometimes keep them for a while.
Right.
I
So
would
you can utilize them. I like I'm just,
I like it.
yeah, me too.
And remember, this is not the final product. This is just another step.
Right. For sure. Yeah, I think that's
Now, okay, so a couple of caveats. So see this like 1 millimeter over here?
right.
Some point you may get food stuck, but
That's
when you
fine.
get to 1 millimeter, it should be fine. You should be able to take that with your tongue.
Okay. And then another question is if we were to bring or like the canine to bring the premolar forward. I don't know. I'm just thinking out loud here. But the front arch, just think like canine forward, like just from the side view. Canine forward. How do we increase the dimension of that space? Is there a way to do it naturally, or is like let's say in the upper arch mainly, like from there to the two front teeth, to just sagittally bring them forward? Is that possible or no?
There are limitations. I mean, because like I said before, the teeth are surrounded by bone, right? Now
Mhm.
that's something like, outside of MSC or MARP or FME, like that's where SFOT comes to play.
Right. Yeah. That's okay. Okay.
Like,
Could
yeah, so you have to be careful. Right now, if you want to get SFOT, that's a possibility, but I wouldn't push the boundaries.
absolutely
That's what makes MARP different than AGA, right?
for sure. Could we bring the two front teeth down just a little bit one more time?
Mhm.
One more, and then is it possible to tip them again, or no? Is that doing too much?
I think it won't look as because now you're bringing in the canine. You're tipping in the canines too.
Okay. Yeah, I'm really just, yeah, I don't know. That looks better. That looks better. That looks better.
Remember, this is just one.
Revision.
Yeah, we can do this all over again after you're done with these aligners.
Right. Go to
You're
the
not gonna
pre.
track. Like we know that you're not going to track.
Absolutely. Can I see the pre really quick?
Yeah, this is nice, Billy.
Okay.
That's actually nice.
Cool. And then that back, that second molar, is there a reason why it's not really like forward, or we're creating a gap for potential something else eventually down the line?
I think the space, that's the space I think that we wanted to create for you.
Okay.
Right? Close up everything. But also keep the molars where they are so you have nice bite force.
Mm-hmm. Okay. This is
I think you and Nawaz decided on that, right?
yeah, he was talking about potential implant action. I'm not against it, you know?
No, that's too small.
So my thing is like when if I at the end of the day when I had my Invisalign done, that gap would be noticeably shrunk. Like let's say I didn't wear my Invisalign for 3 hours of that day, like after I was complete, that gap would shrink, and it was like consistent. It was a consistent battle, and I wasn't sure if we could just bring the molars forward.
That's very unpredictable. I think that purposefully want to keep the arch wide and long. I
Okay.
think you and Nawaz decided, right?
Yeah, I'm not sure. I think this is fine for now. Yeah, this
Let's
is
keep this for now. Let's do this.
would
And the
last.
revision.
This is the last thing, absolute last thing. Could we bring the canines down just slightly, just the canines themselves, just the upper?
Before I do that. Better?
What do you think?
I liked it better before.
Okay. I think I like this.
All right, that's fine.
And they're not clashing.
They're fine, clashing wise.
Okay.
For me right now.
And then could we see the space like go to the butt? So like if it's biting down, how much space do I have in the front? Of like, yeah, let me see that. The canines are fine. Okay. Yeah, that's fine by me. Perfect. Perfect.
Once again, this is we can do this again.
Right.
All right,
Cool.
good.
Yep. Thank you. Oh my gosh, this is crazy. I felt like I was being annoying.
I mean, I enjoy this, right? So like
Yeah.
that's why our outcomes are so good, is like this is fun for me.
Yeah. I appreciate it. Seriously. It means a lot. No, I don't think any other
All right, so
dentist
now
or orthodontist would do this.
Hmm?
I said I don't think any other dentist or orthodontist would do this, would take the time to do this. So thank you.
Yeah, I agree. I would I'm thinking about giving patients the options, but charging a pretty
Absolutely.
hefty fee for this though.
Right.
Because this takes like, because we've done this already for like about 2 or 3 hours,
Right.
right? Um, and literally nobody else does that. In
Yeah.
fact, I know that very few people do clinchecks the way I do them in general, because I take it so seriously, and so I need to be in the right mental state. Like I'm kind of like an artist, so like, you can't force art sometimes, right?
Right.
So like I'll have to have like the right mental state. right ambiance, right lighting. Otherwise, I just won't get, I won't like the outcome.
Yeah.
And so, I can't have disruptions. Like I'm very like type A about that.
It makes a big difference too, you know.
Oh, I agree, but I don't think most Invisalign docs agree. I
When
think for them, they're just getting basically, so the way this whole thing works is the clincheck is it's been AI for the past 20 years almost, right?
right.
Mhm. I mean, not necessarily, but pretty similar, right? So, they come up, these orthodontists and come up with algorithms um that, if this, then that. And so it basically just reads it. And a lot of dentists will go with what the first clinch check gives them, right? And we don't do that.
Right.
I don't do that. Newaz doesn't do that.
Right. That's what separates y'all, man. For real.
I mean, if you saw the way we design, no, especially Newaz with the FMEs and MSCs, the way he designs the MSCs, I mean, I know nobody else is doing it the way he is. Right? That's a guarantee.
Well, thank you again. I really I have no words. I just am very thankful for the both of you to have taken the time to do this. It really, really, really means a lot. I'm just
All right,
ready to be over with it.
all right. So anything else? I'm gonna approve this now.
Nope, this is good.
Let's get this in ASAP.